We're very excited about this afternoon's first session. It's a town hall meeting sponsored by Amgen, and it focuses on communicating quality to patients, something very near and dear to my heart. I also want to welcome those people who are watching live on our live stream and today's town hall discussion on communicating quality to patients. A reminder to those in the audience, please mute your cell phones or put it on vibrate. And also, when we get to any question and answer, go to the mics so that it will be picked up on the live stream. This is a very important topic. We've communicated quality to payers, we've communicated quality to referring physicians, but what do the patients want to hear and how do we present it to the patients? And so we have a great panelist. The first is Gwen Darien. Gwen is the Executive Vice President of Programs and Services at the Cancer Support Community. Wolfson is in the middle, and he's Executive VP and Chief Operating Officer at the ABIM Foundation. And Tom Gallo, who is the Executive Director at the Virginia Cancer Institute. This session is going to be moderated by our Executive Director, Christian Downs.
Well, thank you, Becky, very much. I appreciate that introduction, the introduction of our esteemed panelist. A little truth in advertising, I was a little offended when I walked in and I heard someone say, here comes poor man's Cliff Goodman. But for the lights being on and blinding us up here, I had to point those people out. But no, it's actually, it's an honor to be able to go before Cliff and have such a great panel here to discuss. I think Becky was really right when we were looking at this as an issue. One of the things that we were thinking about in this issue around communicating quality to patients was how much time, energy, and effort we have put in to designing programs, creating models, and working on issues around communicating quality. When we looked at that, though, we looked at it and saw how much of that was actually directed at stakeholders that maybe were not the patient, but instead were insurers. And not that that's a bad thing. But maybe it's worth a pause to say, okay, what are the differences that when we communicate with our patients that we need to say? What do they need to hear that's different? So we wanted to take an opportunity and pull together a panel with many different perspectives. So I'm going to have each one of them introduce themselves again, but to tell us a little bit about where they are, their program, and what they've been working on. And then we'll get to some questions following up and some discussion. And please take your notes, and we'd love for you to ask some questions towards the end. So with that, Tom, I'm going to start with you. Tell us a little bit about your program and what you're doing.
Sure. So I'm the executive director of a large independent medical oncology practice in Richmond, Virginia. We've got 20 physicians, 5 nurse practitioners, about 200 employees spread across 7 different offices in Central Virginia. We are strictly medical oncology, and we have been participants in ASCO's COPE since the founding. We were actually one of the 7 alpha groups that founded COPE. One of my physicians, Chris Desch, was really instrumental in helping develop that program, and we've been COPE certified for the last 3 years now.
Daniel, tell us a little bit about what you've been up to.
Okay. Well, thank you very much for having me here today. I appreciate the invitation. I work for the ABIM Foundation, whose mission is to advance professionalism as a way to improve healthcare. And we've been involved since 2012 in something called the Choosing Wisely campaign. Is anybody familiar with it? Could you raise your hand if you're familiar with it? Not as many as I would think. Choosing Wisely represents over 70 specialty societies and other non-physician specialty societies that have identified 5 things, at least 5 things, where the risks don't outweigh the benefits. And we have also a consumer side to that, led by Consumer Reports. So a physician gets a list of 5 things, the evidence behind why those things should not be done and when they should be done. And the patient gets something by consumer report that translates that into lay language that's understandable and actually tells them what to do as well. And so what the campaign is about is this conversation between patients and physicians. And that is the hallmark of the campaign, is doing no harm and thinking about quality and safety. We do not think about the cost factor in this campaign. We didn't think that would be an engaging kind of platform. And we have found that these conversations do need to go on. And I think it's a good example of how physicians need to talk about risks and benefits. And I can talk more about that, but I think that's good enough for now.
Good. Gwen, give us an update.
Certainly. Well, thank you so much for inviting me to be here. It's really important when you're talking about doctor-patient communication that you actually have the patient voices up here, and so I'm very honored to be part of this. So the cancer support community is founded on the principle that quality cancer care is cancer care for the whole patient, and that of those of us who are many of us are long-term cancer survivors who are involved in that. And when we were first treated with cancer, basically people treated the disease, they didn't treat the person. So our organization provides, last year we provided over $44 million in free psychosocial care for people who were diagnosed, impacted by cancer, both patients and caregivers. And our organization is all founded on evidence-based programs and services. So we have 3 pillars. We have research and training, we have program delivery, and we have policy, because we impact the individual, but we also impact the system. And in order to change the system, you have to, for the good of the individual, you have to understand what the individual wants. In order to help the individual, you have to impact the system.
Great, thanks, Gwen.
Thank you.
So we're going to start with a couple of questions, and Tom, I'm going to start with you. And let's take it down to the patient level. I'm a patient from Emporia, Virginia. I have to go up to Richmond to get my cancer care. I walk in your door. How do I know I'm walking into a quality facility? What's given to me as a patient that makes me get some level of comfort?
Right. Well, and I think that's a multifaceted question. And first of all, obviously, people are often confused, they're scared, and it's a pretty surreal experience for them. And what we try to do, there are a lot of things that they're thinking about. First of all, as soon as people hear that they're diagnosed with cancer, every friend and every relative has an opinion. And the first thing a lot of them do is they go, search the internet. And who are you going to? Why are you going to this person, et cetera. So we, as a group, have, again, we think that COPE certification is important. We really have placed a lot of time and effort on that. We have a website where we feel that the patients can get unbiased information. And obviously, it's part of really trying to provide the patients with some comfort, that they know they're coming to a good place, a quality place. We try to make it abundantly clear that we've been in practice for over 30 years. So again, those things that we feel will give them some comfort. And then obviously the patient communication with the patient. Our staff and physicians extremely involved in that. And in terms of communicating quality, it is not just the physician-patient relationship, it's the entire staff. And it has to be a culture of caring, where people are there to provide care and comfort for those patients, and to try to make the experience the best they can under those possible circumstances.
Now, Tom, you're one of the premier practices in the country. Groups like ACCC hold you up so other groups can say, hey, this is what you're supposed to look like. You participate in a lot of these different quality initiatives that exist out there. You spend a lot of time and energy on those initiatives. How do you think those translate to patients? Let's take COPE. COPE is a great program. I'm a patient walking in and, I've had a cancer diagnosis and I hear COPE. How's that translated to me as a patient?
Sure. We tell them that obviously it is a certification that's a very stringent certification that we get audited on, and that takes a lot of time and effort to go through the process. And again, the quality is a process. So we think about those measures. We think about what we're doing in the practice all the time. to, again, to try to communicate that to the patients. Again, they do have lots of competing issues. I mean, one of the things that we're competing against are when people search the web, there are obviously a lot of sites out there. And the validity of those sites sometimes is questionable, quite frankly. So we want to make sure that they're getting good information from established sources that will give them comfort.
Daniel, choosing wise is very interesting. It's one of these things about doing quality by telling people what not to do rather than what to do in an interesting way. I'll talk a little bit about the consumer piece of this, and has that been incorporated in the patient experience when they meet with a provider? Because that's always the thing we hear, is that there's lots of information that's given to the patient, but it's never digested. Just your thoughts on that.
Right. I think that patients and physicians share something. They're both fearing omission and something that's not going to be picked up, and they don't fear that through a commission of something that's unnecessary can actually cause harm. But I think the campaign is really focused on this patient preferences. Quality is the best evidence kind of divided by or subtracted from patient preferences. And I think that the campaign has really brought out that communication. What does the patient want to do, and something that's not straightforward? And so I think that's been an important part of the campaign. But having both an educated physician and an educated patient talking about procedures and tests that has been recognized by specialty societies and sort of endorsed by Consumer Reports, a trusted name, has allowed a conversation to go on that kind of blocks out other factors in the environment, like payers and health plans and government, and just focused on, let's just have a conversation between the patient and the physician without the noise. And that's what we've tried to do through the campaign, is to really focus, our aim was to increase conversations. And as the campaign began when there was hysteria about rationing and death panels. And we tried to neutralize that kind of thinking by framing this issue around quality and safety and doing no harm. And doing no harm resonates with both physicians and patients. And every test and procedure, except the history and physical, which is the most important procedure, has risks. And we don't talk about the risks. I think physicians and patients both, and there's evidence to bring this out, they both overestimate the risk or underestimate the risk and overestimate the benefits. And I think that we just need to begin to think about what the evidence shows and what the patient preference is, and bring those two things together without the noise of all other things, because I think that does take away from the trusting patient-physician relationship. But if you think about what's the most important thing a physician can do in communication, this has been proven over and over and over again, is to listen.
So Gwen, both Tom and Daniel are earnest. You can tell that this is very important to them in their structure. You tell me from the patient, what's the data say?
Well, I think it's very interesting what Daniel was saying. I was telling you earlier, we have one of our Signal programs is a cancer experience registry, and we have a registry of nearly 8,000 patients and now caregivers who speak to us about their experience with cancer. They answer a series of 100 questions, and some of them are open-ended. And we've learned a lot about what people think. We learned a lot about what they feel. We also learn about how they relate to different diseases. Like I was talking earlier about CML and some of the issues with CML and adherence and beliefs. But we've also learned about some open-ended things. And one of the things that we just did an analysis of was an open-ended question around value. And what was very interesting is that only 5% of the people that answered that question, their answer about value was about medical value. And in that, those people, the vast majority of them talked about what gave them value from a medical standpoint was their communication with their healthcare providers. And that's what they used to measure the value if they looked at it in a medical framework. Most of the rest of them looked at things, existential things, meaning of life, what they've learned, what they've changed, what they're learning to live with uncertainty. And so I think this is really, really critical that this doctor-patient communication and this trust has to be brought to the forefront. And that's one of the things that we do, is we help teach people how to improve their doctor-patient communication. And I also think that it's really important to underscore the other thing that Daniel said, which is that not doing something doesn't mean that you're not doing a test doesn't mean that you're not doing something. You are doing something. You're taking a very strong action. And being able to have those open, honest dialogues is a really critical factor.
Yeah, I want to jump into that just a second, because Daniel, I'm going to put you on the spot about what you think patients can do to improve their ability to listen. But Tom, I'm going to put you on the spot right now, because what I'm interested in is, let's do some compare and contrast. If we're talking about value, talking about quality, give me one or two things you think an insurer wants to hear about quality. Because we know that Gwen just said one of the things that the patient wants to hear about, wants is communication. So what do you think that, what's the first thing when the insurer walks in, they want to know about quality from you?
Cost.
That's right, cost.
I mean, it's as simple as that. I think the insurers, and I think not only the insurers, but the patients often assume quality. The insurers are looking at it more from a strict value, definition, where it's kind of the outcome versus the cost. And that is something that they that they have focused on, is reducing the cost, and whether that cost be the chemotherapy or hospitalizations or the overall cost of care. So they've looked at that. I do have to say that I think that is changing. I think that insurers are like the CMMI project. I mean, people are interested in trying to provide. The current coding system does not really provide any incentive for or any benefit to providing higher quality than the next person. So I do think that some of the programs that are out there now are focusing on changing that and measuring quality, making sure people are following quality guidelines and going out there.
That's right. Dan, so I'm going to put you back on the spot now. I put Tom on the spot with the insurer question. Now, from your standpoint, let's talk about the patients. And what do you think they need to do, patients need to do, to become more informed? What skills can they bring to your discussion, to your Choosing Wisely program that would really make it?
I have to say one thing that I didn't say before, that they'll kill me if I don't say this. ASCO was one of our first specialty societies to join. There was only 9 in the beginning,
yeah.
And ASCO was the first one to raise their hand, so I have to say that. I'm proud to say that. I think that the patient's got to come in with advanced planning, and that's a difficult thing. They've got to know what their concerns are and jot them down. I think the best thing, particularly a cancer patient, can do is not go alone. I think having a family member in the visit really helps the patient relax a little bit, because they're under a pressure cooker to really understand a lot of information in a very, very short time. I unfortunately have a brother-in-law. He doesn't go to a visit without at least one person, and it's usually 2 or 3.
Interesting.
And so, and they take notes better than physicians take their notes in this case. So preparation is really important, but the physician's got to be presupposed to listen. And for a patient to go into a visit and not have a listening physician is a hard thing to overcome, particularly when you're so vulnerable with a disease like cancer. So I think we have to find doctors that will do that and have that communication skill, and to pick and match those doctors that will. So communication skills is really important. It's a part of board certification, communication skills, and it's a standard that, there was just an article in the New York Times about, physicians tend to lecture and not listen, and they need to ask open-ended questions and begin to sit back and listen and not to lecture, because the biggest source of information is that patient.
So I hear you saying, hey, a patient that comes in, make sure they have some additional resources with them.
In our campaign,
another person,
we
little
give
homework.
We give them consumer reports translations that hopefully they have in their hands. They might not, but they can get them on our website or on the Consumer Reports website. There's a hospital here from AMC who has built into their EMR the Consumer Reports recommendations and provides them at the point of contact with those things. So maybe physicians have the obligation to provide information to patients that allows them to make choices. And I think that if a physician saw themselves as a navigator and allowing for choice, they would be much more prone to educate.
Let me Gwen, I want to get to you on this in just a second, but Tom, why don't you talk a little bit about navigation? Because I think to some degree, navigation can be used as one of the vehicles to communicating quality with patients and demonstrating quality with patients. What have you seen that works well with navigation, and what's been some of the challenges with navigation?
Let me actually make one other point about the education process, because I think that's really important. And in our practice, and I think many practices focus a lot on the patient education. Our nurse practitioners, our physicians, our nurses, I've got two of my nurse managers here today who've been instrumental in setting up a system for us in terms of education. And we also provide just probably an overwhelming amount of information to the patients, including a detailed National Coalition of Cancer Survivors did a fantastic job of putting together, I think, a 10 CD set, which obviously people can't listen to all at once, but really, really good patient education materials. In terms of navigation, navigation is important, and I do think that the system that we have currently is still fairly fractured. And so one of the biggest issues that cancer patients face is that they're often dealing with multiple specialists, multiple sites of service that they have to go, and just coordinating all that. In some practices and some hospital departments have navigators, specific navigators. What we do is each one of our physicians has a nurse that works with them that essentially acts as a navigator and tries to smooth the transition between appointments and care among the different sites of service and the different tests that people need to get.
That's interesting. It brings us to an interesting point about navigation and how that works and the potential for the quality piece. But what are we seeing from the patient perspective around? Is it almost too much? I mean, when you walk in the door, are you almost overwhelmed as a patient? I mean, I'm sure that goes from patient to patient. But
I think that's absolutely it. It goes patient to patient, and I think the responsibility for education is a joint responsibility between the provider and the patient. And everybody has a responsibility to check in with each other about how much you want to know, what kind of information you want to have to make informed choices. I also like, rather than navigation, I like a kind of building self-advocacy skills model, because I think navigation is it doesn't give the person who is making these decisions, sometimes doesn't give them the ability to build the skills to make their decisions. And I think that's a really, really, really critical thing, especially as we're talking about an increasingly complex set of choices that we as cancer patients make when we are looking at the treatment that we're taking. And I think, one of the things that was really striking, there were two things that are related that were very striking from the Cancer Experience Registry. Our first group of patients were breast cancer patients. We did a proof of concept concept in breast cancer. These are highly activated. This is an online initiative. The women are mostly women, they're mostly younger, they're mostly well educated. Half of them said that they did not understand the goals of treatment. This is stunning.
Yeah, I was going to get into that piece too.
That is stunning. Then we also found out that in all of our, and all of the people in the registry, most people who access advocacy groups, access patient groups, tend to be more what we would call an activated or an empowered patient. Half of them did not feel prepared to make treatment decisions. So I don't think it's the quantity of information. I don't think it's necessarily, I mean, we are, as cancer patients and survivors and any kind of patient overwhelmed by choices, and we just want to hear somebody tell you it's going to be fine. I mean, ultimately that's what we want to walk in and do. But I think it's the quality of the information and it's the quality of the conversation. So both sides have to come with a sense of curiosity, with a sense of listening and an openness to listening to the values and the goals of the person who is going to ultimately be receiving that treatment.
So Gwen, that's a very revealing piece that you bring out about how the people who filled out the survey did it online. Generally your assumptions are somewhat technologically savvy,
right.
Access, frankly, to a computer,
right.
Probably interested in the participation from an intellectual
yes.
level. And they said that they didn't understand it. My gosh, what happens to working folks who come in? I started off time with the example of someone from Emporia, and for those of you who aren't Virginians, that's a very small town near Richmond. But I'm coming out, and I don't have these skills. I haven't had the life skills to do this. How do you communicate quality to someone?
Well, I think there are multiple facets to this. So I think part of what happens in these discussions is that we end up being a little reductive because that's the only way we can approach these discussions. So I think part of it, not understanding the goals of the treatment, is also that the physicians don't always understand the goals of treatment. So you look at literature around physicians and clinical trials, and and physicians thinking that it's going to be that the goal of a clinical trial is a cure. So some of it goes from all sides.
Yeah.
It may go from the family member or the person the caregiver that accompanies them, it may come from the doctor, it may come from the patient. But I think that we know that we have to increase the health literacy of this country. We know that it's low generally, and we know that we can build skills. So the way that you build skills with people, I think, is that you take something that they're familiar with and use that as an example of how you build a skill. So if I'm looking, my first career before I was diagnosed with cancer was in contemporary art, and so I look at the students that I taught who took photographs. I would use that as the framing metaphor for learning about other skills. So I think there are multiple ways of approach. I mean, I would be interested to hear what you would have to say about that.
Yeah. So Daniel, that brings me to the point. We heard a little bit from Gwen about what are we going to do with not only patients in general, and I think it's interesting the consumer reports aspect of what you all have put together, something that people can understand and most people relate to. Do you see a challenge from a quality communication standpoint for folks that may not be familiar with consumer reports? And that could be not only on the one end, you could have that on the other end too. People who who are so technologically savvy, they're more into Yelp than they into consumer reports. I probably dated myself there by about 5 years by using the term Yelp. But what do you see as a challenge?
I just
there?
want to reflect on something that was said. I think we have very much of a cure model and not a care model.
Right.
And I think that's, we're so set on cure that we really don't take the patient where they're coming from and what goals they have. So, Consumer Reports is a slice of Americana. We also have had many articles in AARP, another slice of America. And we've had many articles, for instance, in Vogue magazine. They did an excellent article about choosing wisely. So to have a consumer campaign is way beyond our reach. We need to have partners in that, and we have had a lot of partners like AARP, like National Business Group on Health, and Consumer Reports, but it's a huge undertaking, and it's going to be a slow grind, I think. I think patient advocacy groups are behind us and working with us, but it's going to take a long time because the society is reinforcing a message every day that more is better and that technology is better. So on our side, we're focused on the physician because we can get our hands around physicians a lot better than we can 250 million people.
That's a great point. So you had mentioned the piece about more is better and the high-tech piece. I'm going to turn to you, Tom, because we have a lot of providers in the room, and you're asked to make investments every day, and you've made big investments on the infrastructure piece of your program, collecting data, doing that type of thing. Some of it, as we discussed at the very beginning, was for payer purposes. Mm-hmm. What do you think your investments are going to be in the future as it relates to patients and communicating quality?
So, I think the most important investment that any practice or system can make is in its people. There's no doubt about it, and I think that often, is underestimated, the power of the staff. And so you have to have tremendous caring staff. They have to be well educated, they have to be well trained, they have to be able to deal with very difficult circumstances for their patients. And so we will continue to invest in our people. That's something that we've been very cognizant of, even through the times when the reimbursement has been squeezed and our costs are going up. We are continually trying to invest in our people, and we will continue to do that. And my physicians who own the practice recognize that and are willing to do so. So that's number one, definitely. But information systems are really important, and we've been we're an early adopter of an electronic medical record. We've been on that electronic medical record for I guess about 8 years or so now. But we've got to do a better job of getting the information out of the electronic medical record and using it, applying it for the purposes of quality going forward. And I think that today that is starting to happen. There's a lot of data mining capabilities that are out there, a lot of different programs that are out there to do that. And so we have started looking at those and working with those systems, and we think that those are going to be important going forward.
So Gwen, that's Tom's investment. That's the money he's going to lay down, hard-earned money he's going to lay down. Go ahead.
Can I say something else about that? And also, our facilities are comfortable. They are not the Taj Mahal. And sometimes I do think that patients think that if they see a shiny new building with lots of fountains and marble floors, granite countertops, that is a definition of quality. And that is not necessarily the case. And so rather than spend money extravagantly on that, we're going to put it back into our program for the patients.
So it's not comparing aquarium sizes. It's really how many gallons your aquarium is. But when you hear that's what Tom's investing in,
yes.
And he's talking about data systems.
Yes.
He's talking about information. He's not talking about granite countertops, which I think is a very interesting piece. Mm-hmm. Patient perspective. Is that where we want the investment to be?
I think that is a much more valuable way of investing than granite countertops. I think that what we see over and over again is what people care about is their relationship with their whole team. They care about openness. They care about access. They care about compassion. And so I think that is an absolutely important investment. I think the other thing that's really critical to patients, and I've been in patient advocacy now for about 18 years, I believe, is that we have confidence that our healthcare providers are up to date on what is out there and what is out there in the literature. And that is a very difficult thing. There's more and more literature out there. But I care much, I think that I and my colleagues care much more about the level of knowledge and compassion and communication and curiosity of our healthcare providers than we do about what the place looks like. Now, has to be, it better be clean. But
I said
aside from, I mean, the cleanliness is the, but I think that's really, really critically important. And I think in some ways, I mean, it depends on the person. Some people are skeptical if you saw the Taj Mahal, you'd be a little skeptical. It's like, where is the money going? Where's it going in terms of patient care? But I think that's really, I think investing in people, that's where care happens. It happens between people. It doesn't happen between countertops and couches.
It's just kind of like the people who walk into the casino and say, I can't believe, how did this get so nice? You know, and I always find that interesting. But Dan, I want to wonder, I mean, from your perspective, and I want to start to look at some of the issues around that we're having now around all the data that's available out there and all the science that's coming out right now. And again, I think choosing wisely is interesting, focusing on what not to do. But we have a tremendous challenge in medicine, but really particularly in cancer care. Things are changing so very quickly. Keeping up with all of that information is incredibly difficult. And then translating that in a way that patients can digest it, that's going to be a big problem, do you think?
Sure, and one thing that we haven't talked about of all the quality information, and I think this is going to be a rapid trend, that patients, now that they're being cost shifted, are going to want to know something about cost. And frankly, physicians are ill-equipped to talk about financial harm. And we haven't talked about that today, but I think that's on the horizon. I was just at a conference today, Robert Wood Johnson Foundation, talking about cost transparency. And that's a huge issue, and it's a huge issue in cancer, I'm sure. And so we didn't talk about that. So the data, probably we have too much data and not enough critical data for patients.
Interesting.
So we have a lot of measures that we think are related to outcomes, but we don't really have great evidence to know that. But we do want outcomes information. That's what patients want. But we're still very much focused on process information. Cancer screening is a good example, actually, of good proxies for processes that relate to outcome. But we know that people are being screened too much as well. So a lot of data, but what the patient wants, frankly, is they want information about their doctor, their ability to be compassionate, to show empathy, and to listen. And those are the information. And frankly, and I know people don't like this trend, but they want to hear it from other patients. And they want, we live in a society now that has Wikipedia as a business model. That's very important, I think, to understand. Choosing Wisely, I think, picked up on some of those concepts of bottom up. You invest in people, but invest in people bottom up, not top down. And that's what I think Choosing Wisely did. It unleashed physicians to figure out how to solve the problem rather than having top-down solutions. And I think those kind of non-hierarchical relationships are really going to be important in the future. And so measures, well, maybe measures should be at what's important at your place or what's important at your place. What are the gaps? We have a measurement system that's very top-down. Yeah. And I don't think that's going to serve us well. Now, we do need cutting measures, potentially, I don't know. But what's more important is that his shop provides better care because he's got better data that shows the problems in his place, not somebody else's place. And I think as soon as we get down to the local level, we'll have patients more engaged in their data, and there'll be more engagement of physicians. But national data, I think we really need to begin to question it and begin to get more local.
Well, let's walk through the cost door. Mm-hmm. We've already talked about technology. Right. We've talked about empathetic skills and listening skills. So let's say I walk into Tom's program. It's clean, it's nice, it's Corian, so it's not granite, but we'll live. The doctors are friendly, the staff is really strong, and I feel like they've got the numbers. Now we have a cost issue.
Right.
What do we think What are we hearing from patients about the cost issue?
We're hearing a lot from patients about cost, but we're also, I also want to make the point that cost is not just about the financial costs. So we're hearing about what people have done because of the medical cost of cancer and then ones they've done because of the human cost of cancer. We've found through the registry that a significant percentage of people, 25%, are actually taking out money from their retirement funds.
What was the percentage of that?
25%.
25%.
Are taking money out of their retirement funds for cost of cancer. And this is also a group that is insured. Most of the people in our registry are insured. So we're not talking about an uninsured population. We found that people are doing things like we know they're foregoing vacations, we know they're foregoing family trips, we know that they're depleting savings, we know that they're asking for loans from their friends and family. We've also found that there's a tremendous impact on work, and one of the most striking findings that we're going to drill down into is we have different sub-registries for different disease types, and one of them that I mentioned earlier was on metastatic breast cancer. We found that nearly 50% of the women, and they're by and large women, 98% are women in that registry, had a change in their job situation. And we know that employment is a significant predictor of outcome. 25%, half of those 50% said that they experienced job discrimination. So this is something that we have to look at because that's a huge cost of cancer. And then we've also found that people, on the one hand, when you ask people about value, it's part of it is how they define value, but we found that the vast majority of people wish that they would have gotten more financial information about the cost of cancer from their healthcare providers, and that was a huge lack, and that's something that I think we can all work together to address.
It was the retail costs, for lack of a better term,
yes,
from the provider.
Yes, and copay and things that are, I mean, if you ask, often when you ask a doctor what's your copay for this medicine, they will have no idea because it's too complex.
Tom, that's a challenge. I mean, you walk in. I'm not walking into, it's not. There's no price on the wall. I mean, you almost can't do it until it's over, right?
Well, I mean, you can estimate it, and you're right. I mean, the physicians don't have an idea a lot of times, and they have too many other things to worry about. So, what we have had in our offices are financial counselors in each office, and they essentially do a financial consult with the patient before treatment starts. So that is something that we have found to be extremely helpful. And what that does is not only does it give the patient an idea of what the overall cost to them is going to be, but it also helps identify gaps. And then if there are gaps, what our financial counselors do is they seek assistance, whether it be through co-insurance assistance foundations or through pharmaceutical programs. Again, it is something that we have done for many, many years, and our financial coordinators have brought in assistance in excess of millions of dollars on an annual basis. Yeah. Now, that being said, with the increased cost of care, there are more people competing for these dollars. And so we do need to, find other sources and make sure that people keep replenishing the pots for these things so that patients have access to care.
Does that estimate happen before treatment even starts?
It does, yeah.
And would you fold in any of the other specialties, the surgical piece, too hard to do, right?
Yeah, it's too hard to do. You're right. And so you're right. I mean, it's just a piece of their care. I mean, oftentimes these patients have surgery, radiation, and chemotherapy. We can provide them with the medical oncology side of it. We really can't provide them with the radiation or the surgical side.
So Daniel, it's a big challenge. We can't come up with a sticker price, and then one of the things we talked about was the cost piece. From your perspective, where do we have that discussion? I mean, it could be the medical oncologist, but he's only got a piece, or she only has a piece of that. The surgeon has a piece of it. The radiation oncologist has a piece of it.
I don't have a good answer.
There's not one.
And because the physician is at a complete disadvantage. The insurance companies know what they're going to pay, and there's multiple insurance companies. And we've been debating internally about whether we should put this on the physician's head because there are other things to do, and they're not in a position to even know. Now, could they think about mitigating strategies for their patients, about lower cost ways of going? Potentially, but at what sacrifice? Sacrifice of quality? It's a really sticky issue, but the physician's got to know, I think, at least their coverage and where they're going to be vulnerable to particular financial harm. Yeah. And, you know, what does that mean? I don't know exactly. Does it mean a generic over a brand, maybe? Sure. We know that's an easy one. But there's a lot of other things that could happen that could mitigate cost. And to enter that arena, I think is difficult. I really do. And price transparency, I think, is a great idea. But when I'm sick and I need some care, I'm not going to go shopping.
Yeah, it's kind of inelastic, isn't it?
It's basically the concept is somewhat flawed. Yeah. Because of when you get care, under what conditions. Massachusetts has a regulation now. You are required, if you're a hospital, 48 hours to tell the price of a service, and that might be the way to go. But that's probably the only solution that I don't like, but yeah. the only solution I have at the top of my head.
Gwen, give us some advice. We can't give you a sticker price.
Right.
You know, it's too hard.
Right.
You know, it's not going to be accurate.
Right.
It's probably not going to answer your question anyway.
Mm-hmm.
So while you're thinking about the answer of what can we do to overcome that gap that exists in communicating quality to patients, I'm going to ask folks to turn up the lights so that we can have some questions. We have about 10 minutes left. So please feel free to come up to the mic and ask some questions. But Gwen, I'll put you back on the spot. What can we do?
Well, I think that having financial counselors in practices is not the norm, and I think it would be a great norm to have. I think there are also many advocacy groups that can help point the patients in the direction of help and advice. We have a helpline that is that people call in. If we can't help them, we refer them to our partners, and then we check in with them and say, did you get the information that you needed? The helpline has a database of thousands and thousands of resources. So I think one of the ways to deal with at least helping patients understand costs and get help is to refer people to patient groups and have those patient groups generally have a lot of resources. This is a very different path in terms of cost. But I think one of the things that we didn't, that as we're talking about data and what we're learning, in our registry, patients, it's a multi-stakeholder registry, and the questions were developed by multi-stakeholders from medical professionals to patients to psycho-oncology professionals. But one of the things that we're learning is we're learning a lot about what patients are doing because of the cost of cancer. And so people are doing things like skipping doses. People are cutting pills in half. People are doing things that relate to either financial or belief systems about outcomes. And I think we need to understand more about what that impact is of the financial cost on the long-term cost to society and the long-term cost to that individual. So it's not just the cost of your treatment, it's the cost of what happens if financial toxicity, and I believe we're going to hear from Yusuf Zafar tomorrow about financial toxicity, what that impact is, which is much broader than just what the cost of your treatment is. So I think it's
I just wanted to add that I think it's a problem that needs multiple people involved. No one of us can solve this problem. We need the insurers at the table. We need the delivery systems. We need the physicians. We need the advocacy groups, or we're not going to get a handle on this problem.
Dr. Beisenberg?
Thank you for the presentations. I wanted to first ask a question, but before I do that, I want to point out some inaccuracy I think that I heard. I don't think it's established that patients are cost sensitive in medical decisions, and particularly in cancer. And I will point you to a piece of data I know of two pieces of data. One published out of Yale last summer in the Journal of Oncology Practice, which was a survey, so has the limitations of all survey data, asking patients whether they want a lower cost, lower financial impact therapy and under what circumstances. And the overwhelming majority of patients said not only do they not care about society's costs, but they don't even care about their own costs. And the second piece of data is in my hand from our own institution, where we asked similar questions and got a very similar response. Even among people at highest financial distress, which according to Dr. Zafar is about 40 or 50% of the community, patient community. And what that implies is that despite ASCO's strong recommendation to us to have these cost conversations early, the patients don't understand or have a different understanding about the differential impact of more expensive therapies compared to less expensive therapies. So I don't think they're necessarily willing partners yet in this conversation to somehow constrain this financial injury, which you've pointed out. So that's a statement. My question to you was about the situation where this concept of shared decision-making can sometimes lead into bad medical decisions. And I'll give you two examples, both around breast cancer. One is the issue of contralateral mastectomy, which most people in this room know is rising at a very rapid rate for reasons that are not clear. That's not a cancer operation, that's not a cancer recommendation, but we have over 25% of women opting for a second surgery, talk about harm, or an extended first surgery for no cancer benefit. And the same scenario applies to patients who request, or in some cases demand, after adjuvant therapy that they get imaging and or tumor markers done frequently because they know someone else who's having it done that way, or they read about it on, as you said, on the internet. And so that actually is an ASCO choosing wisely topic, and yet the patients often request it. So is it quality to give the patient what they want, to engage in shared decision-making so that the patients get the sort of degree of follow-up that they want, or is it better quality to say, no, I'm sorry, we don't do that here. If you want that, you'll have to go someplace else.
I could address that.
You want to take that in? Go.
I think I can. I think that when the evidence is clearly contraindicated or a test and procedure, I don't think it's shared decision-making. I think it's a directed decision. I think when shared decision-making comes in, when the evidence is poor, and there's a lot of patient preferences that are involved, and that's what shared decision-making is about. But choosing wisely has both, and really more about a directed decision than a shared decision. There are some recommendations, PSA testing, for instance, of course, although some people don't think that's a shared decision-making, which is a really interesting debate that we won't have today.
Well, I think there's always the tension between the individual and what the population evidence shows, and we see that over and over again. I mean, a number of years ago, I was on a panel and giving a talk about the lack of evidence about efficacy of mammograms for, I forgot what age it was at that point, but it was after a consensus conference came out. And I had women follow me into the bathroom yelling at me about how they wanted their mammograms. And, you know, I'm a cancer survivor. I understand these things, but people want to feel like they're doing everything possible to avoid having their disease. And I cannot tell you how many cancer survivors I've talked to who people come up to them and say, what do you think you did to get your cancer? So there's still a culture of you didn't take your health into your hands to the extent that you prevented this bad thing from happening to you. So I think it's very, very complicated.
Faye, is that you?
It's me, hi.
Oh, okay.
I just have a question. Do you think we're going to ever hold the insurers accountable to helping us let the patients know what things are going to cost before? We're paying them a lot of money, and they're making physicians and facilities help the patients, and we come up with numbers that aren't even accurate because there's so many plans and we don't have that information. Why can't we hold them accountable and make them all have where you can go online and put in different treatment options your doctor gave you and come up with the costs to you and your insurance company so you can figure out better? Because no matter how much we try and how many people we pay to put in that position, it's very inadequate because insurance companies give you a little chart and I still don't know what things are going to cost when I have my health care done. So these cancer patients are never going to get an answer until we hold the insurers accountable.
Faye is going for the pitchforks. Tom?
Yeah. No, to her point, I mean, I absolutely agree. I do think that the carriers are starting to make strides in that area. They're starting out with some of the higher cost radiology tests, and they're going to expand it. They have plans to expand it. Now, you're right, it's not all carriers, it's not all plans, so it's probably going to be your larger carriers and the larger plans in town. But the people who hold them accountable are the people who buy the insurance. And the employers are starting to hold them accountable. So they are starting to look at ways that they can publicize this information so people can make informed decisions, and hopefully those decisions will lead to some reductions in cost.
Great. Listen, let's take a moment. We have to wrap up now because we're going on to our next session on big data, which is going to be very, very interesting. Dr. Abernathy's session on big data. But let's give our panelists a round of applause. Thank you very much. Give us a minute to just transition between this setting and Dr. Abernathy's presentation, and we'll be good to go. Thank you.